the global leader in software for cancer risk assessment. Our mission is to identify high-risk patients for screening and prevention to improve patient care and outcomes. The software was first developed in 2006 at Massachusetts General Hospital, and Newton Wellesley Hospital was the first site to go live. We were spun out of MGH in March of 2014, and I joined the company in October of that year. Our medical advisory board consists of some real thought leaders in breast health. Dan Kopens on the imaging side has been a pioneer in numerous breast imaging modalities. Mark Lipman, currently chairman of the medical school at University of Miami, but was previously head of the medical breast cancer section at National Institutes of Health. And Giovanni Parmigiani is an expert in risk modeling. In particular, he was the creator of the BRCA Pro model, and he guides us in terms of risk modeling and things we should be thinking about in the future. The Affordable Care Act also speaks to collecting family history and risk, particularly Affordable Care Act Meaningful Use Phase 2 talks about family history being an important set of information to capture and address from a prevention and screening perspective. Our solution to dealing with the complex models and guidelines for prevention and care is that we develop risk assessment tools for guideline appropriate care with a focus on our return on investment where possible for healthcare providers. The return on investment piece is specific to breast imaging in that most women who meet guidelines for breast MRI don't actually get breast MRIs. 99% of women who meet American Cancer Society guidelines for breast MRI do not actually receive appropriate care, and Hughes RiskApps can help identify that. So if you use our system in an imaging setting, we can help boost breast MRI volume significantly and associated with revenue. That's only part of our business, but we always feel it's important to mention that. More to the point, our tools are workflow integrated decision support tools. Patients can enter data on tablet computers or over the internet, risk calculations using all of the standard models and guidelines based on those models. The end result being patients receiving appropriate care. Both MRI and potentially genetic testing. Here are just a couple of case studies looking at actual compliance with guidelines. A small study at Newton Wellesley and two bigger studies, national studies, but documenting the fact that women are not receiving MRIs that are guideline appropriate. So these are just a few snapshots of how our system works. Clinicians, our goal is to minimize any impact on clinicians, automate as much as possible, and take the load of doing risk assessments off of both support staff and the larger team. We automatically generate follow-up letters both for insurers and referring physicians, for high-risk patients. And here's a sample of one of those letters. A few sample screens from our system. I'll actually hop out in a moment and actually show you a running version of the system. But these are just a few of our screens. You can switch languages, etc. But I'm gonna hop out and show you the actual working system. And as I mentioned earlier, the system generates a pedigree on the fly. Bottom line, our goal is for women to have the screening and prevention they need to prevent needless cancer deaths. I'm gonna hop out now and show you our patient interface. For a second, we're gonna pretend I'm support staff in my imaginary clinic here. And I'm identifying a patient who just walked in. I hand her a tablet computer and ask, is this you? Is that your medical record number, your date of birth, and your name, etc.? If she says yes, she's off to the races and doing a survey. And as I mentioned earlier, the questions can be switched to different languages on the fly. The risk assessment results are translated back into English for the clinician. And I'm going to complete this risk assessment here. So this patient has 5 to 9 drinks per week, is a smoker, date of first period, yes, and this patient has never been pregnant. I'm intentionally going to make this patient a high-risk patient, just so you can see what a survey looks like for a high-risk patient. For a low-risk patient, the survey is typically done in 3 or 4 minutes. A higher-risk patient will typically spend 6, 7, 8 minutes answering questions. In this particular case, I'll say that she did have a breast biopsy, but the results were negative. If I said yes to hyperplasia or to LCIS, she would automatically be high risk. So I'm going to say no to both of those questions. This is not really relevant to risk assessment, but our founder is a surgeon, and he always likes to have this question in there. Some of the leaner versions of our surveys don't capture this information. Do keep in mind that the survey you're seeing here is the leanest version of our risk assessment. There are much more involved versions. We have nearly 30 different risk assessment surveys that are used in different settings, but in a screening setting, we try and give the leanest survey possible. We don't, in this version, capture unaffected relatives, but there are defaults in the models for cases where you don't do that, and there are a few other risk-relevant questions that are not in this survey, just because this is the goal is to get this survey done as quick as possible. I'm going to give this patient a history of chest radiation to intentionally boost her risk. Say that she uses birth control and started at a young age. If the patient realizes they answered a question incorrectly, they can always go back and change it. And I'll say that she took birth control for quite a while, continuously. I'm going to say no to fertility drugs. She's Caucasian. She's not Latino, which would actually reduce her risk. And she's also not Jewish. Being Jewish alone almost boosts a person into high risk automatically. Have you ever had cancer? So I'm going to say yes. And I'm going to say this patient had lymphoma, which explains the chest radiation that she received. And she was treated for lymphoma at a fairly young age. If I say no to the next question or two, the survey is done, and that would be although I already boosted risk, but that's mostly a low-risk patient. I'm going to say that this patient does have relatives with a history of cancer. I'll say a sister. If I say a first-degree relative had breast cancer, the patient is automatically high risk. Ovarian is nearly as significant in terms of risk, but it doesn't automatically make someone high risk. I'll say that this sister had ovarian cancer at age 25. I'll say a maternal grandmother, a second-degree relative, had a history of breast cancer. You can say one breast or both breasts. I'll say she had a history in one breast at the age of 38. I can look at the father's side of the family. So let's say the paternal grandmother and the paternal grandfather both had a history of cancer. Let's say this grandmother also had breast cancer in, I'll say both breasts. The first at age, and both at the same, they were both detected at the same time, at age 34 and at age 34. Notice that when we switch to the grandfather, the types of cancer one can get change based on gender. We'll say the grandfather had a history of prostate cancer, and that was diagnosed when he was 62. If a patient has had genetic testing, we offer the ability to capture their BRCA status. We probably wouldn't have done that 5 or 6 years ago, but a significant subset of the population, if they've been tested, will know what their status is. I'm going to say no to this particular patient, and we're done. So we're going to capture her email address for follow-up if she wants to do that. And the patient wouldn't see this screen that's currently running now, but I'm running my risk models in the background on my demonstration system. Really, the only thing the patient would see is this screen. You can return the tablet computer to the medical assistant, or if they were completing the survey over the web, they'd say your survey is now complete. I'm going to hop out of the patient interface and take a look at some of the automated follow-up that we have. So here we have a letter to the referring internist or OBGYN. This particular patient's lifetime risk of cancer is greater than 20%. According to BRCA Pro, it's 22.48%, and Tyrer-Cuzick, it's 35.9%. We also, for the referring physician's ease of use, we attach a draft letter of medical necessity that they can use for the insurer to request an MRI. The system also generated some smoking cessation information automatically for this patient. And this is really intended for either the clinician who is involved in the screening, or perhaps this is sent back to the referring physician. This is a total summary of their risk assessment. We see that there's a suggestion that genetic testing may be indicated for this patient because their risk of mutation is greater than 10%. And likewise, an MRI should be considered because the patient's lifetime risk of cancer is greater than 20%. We see all of the survey questions that have been answered by the patient and all of the risk scores on all of the models for this patient. And we snuck in a few GI model risk scores as well, because we can do that with the same information, and generated a pedigree on the fly. I'm gonna hop out now and take a look at the actual clinician interface. So if in a genetic counselor or a physician that wants to take a look at their patients that have been identified as high risk, I'm going to include my test patients here. We can see all the patients that my clinic is tracking for being high risk. We can even track whether they've had follow-up of genetic testing or an MRI. I can drill down into an individual patient and take a look at their survey results. Perhaps they're back in my office and they realize there are a few additional relatives. I could enter those here, affected or unaffected. I can take a look at the pedigree that was generated on the fly and format it if I want to a little bit. I can zoom in or zoom out. I could also add additional relatives and cancers here at the pedigree level, and it would populate back to the database and be saved. So we have an integrated, full-blown pedigree tool driving off of the risk surveys. These are some of the things that we could possibly do if we were providing both a risk engine and a back end to Athena's existing tools. There is quite a level of detail, and in fact, a longer version of this presentation with one of our real genetics risk gurus, could take an hour or two looking at, adding a full family tree with numerous affected and unaffected relatives. You can add twins or half brothers, monozygotic or dizygotic twins, et cetera, et cetera. I'm gonna hop back out to my clinician dashboard. So here on the right we see my high risk of mutation that I'm tracking, my lifetime risk of cancer queue that I'm tracking. We have automated management reports, genetic tests that can be ordered and tracked. But this piece is really a comprehensive risk clinic tool that's fully integrated with the front end patient risk assessment piece. That's a pretty good run through of the system. There are potentially lots of ways that we might be able to help the Athena project out, and we would love to continue the discussion.